Okay, so welcome to another Sydney Lectures for November 2022. Yan Jin, if you'd like to give us a quick intro of yourself and go ahead and get started whenever you're ready, that'd be great.
Okay, well, thank you, Michael, for the introduction, and good to see everybody. I know some of you, and hopefully throughout the session, our discussion, I'll get to know more about your research and really use the lecture as a way to keep building crisis communication fellowship globally, right? So a bit about myself, and I am a professor of public relations and also the C. Richard Yabo Professor in Crisis Communication Leadership at the University of Georgia in the US. Right, so today my topic is about health crisis communications. I do have some slides I'm going to use to really aid the discussion about a very complex communication challenge that confronting all of us, no matter where we are in our globe. So I'll be using some slides, and hopefully this will be a discussion starter. And at any point in my discussion or presentation, please feel free to raise your hand or raise your voice and to engage in a dialogue and conversation from here. Okay. Okay, can you all see my screen okay?
Yeah, yes.
Okay, great. Thank you.
We're getting the
okay.
thing there. So if you want to go to full screen or something.
Okay.
There you go.
All righty. Okay. Yeah. So I'll start with some of the most recent observations and reflection about public health crisis communication. But still, ever since 2020, we're already 2 years in the COVID-19 communication challenges, and we are still in a pandemic mode for the most part of the world, right? And if you remember, we recall that fairly recently, back in August, CDC director actually talking about there are lessons to be learned about how CDC as a public communication, public health agency can learn from the failures and lessons. How can we do better? So I think lots of those kind of questions, reflections are really applicable to a lot of us as scholars and practitioners in the public health crisis and risk communication arena. And then the headlines continues. If you look at just in October, there are headlines about public not hearing COVID bivalent booster messages, and also even research labs questioning or fears about the infodemic overblown from the eyes of the public, right? So there are lots of questions that particularly interesting, relevant, and pressing for communication scholars like us. Okay, and this is way before COVID. So in 2019, my research team published an article in Public Relations Review. So a year before that, we conducted an interview of communication information officers in the US. From the local, state, and federal level, we talk about, so what are the challenges that we are facing as PR communication scholars and practitioners in particular? What are the challenges when it comes to infectious disease communication? Particularly, we frame that as infectious disease threat. We call it IDT communication. So the reason why I'm showing that here is that still during and after COVID, some of those challenges comes from managing communication still prevail, still relevant to all of us here. So a few highlights, right? So the time and resource constraints comes to visualize data, translating the findings, comes to monitoring, responding to social and digital media communication. How about the diminishing levels of trust, right? So lowering trust of a government, about news media is still so relevant. And then we also have the need for public information officers and public health agencies to strategically use and integrate social media platforms in conjunction with traditional platforms. How do we also activate interpersonal communication? So all these findings that we reported and published in PR Review in 2019 over the past 2 or 3 years now still so relevant and pressing, right? So what did we learn? What are we going to look for in post-COVID era? That's something I would like to encourage all of us as scholars and communicators to think about ahead together. Okay, so another concept I would like to introduce is that public health crisis is one of those most sticky crisis issues that we would like to argue for. So what is sticky crisis? So this is a concept that our crisis communication think tank at the University of Georgia, we started to explore as early as 2019. So what has been a sticky crisis? Think about the sense of being sticky is that being sticky is that it's complex, it's not going away, and it's challenging, it's like to occur no matter where we are. So they are complex, challenging, and public health crisis is absolutely one of them. Okay, and another background is that I would like to invite all of us to think back in the context, in the landscape of conflict management, and in which we put risk and crisis concepts into a bigger landscape. Okay, so when we talk about public health crisis, another concept inevitably is health risk, right? So risk is something like negative, likely to happen, but not yet happened yet. And crisis is when the risk becomes materialized into something threatening reputation, threatening well-being, threatening the business operation. So in this chart, which I presented at another conference in 2021, is that give us a perspective. So we talk about risk and crisis communication, including health crisis. What are we talking about? So if we think about crisis communication, risk communication as a way to protect something we really care about, may that be public health, safety, may that be organizational reputation, may that be a brand image or asset. So we can think about, when we think about public health crisis communication, it's a really function of managing communication. It's also managing informational competition and conflict. Okay, so underneath the strategic conflict management, we can look at health risk communication. We can think about health crisis management, which including prevention, preparation, response, and revision. And I often emphasize this to my students and junior scholars that when we think about health crisis management and crisis communication, this applies to health crisis communication as well, is that there's a difference between crisis communication and crisis management, right? Because the communication only happens when an actual crisis occurs. We have to respond via different communication strategies and tactics. However, the management function happens way before and after that. So the topic we're going to explore today about public health management is going beyond just the communication element part of it, right? So how do we really conducting risk assessment? How do we really think about how public health organization, how PIOs, and how we as practitioners can really become more proactive in anticipating what's going to happen ahead of the curve, understanding the hearts and minds of our stakeholders and public, and really knowing the challenges that our public health information officers are facing, so we can be more preventive. We can be more be better prepared for the future public health crisis and risk ahead of us. Okay, so but regardless, if we think about public health crisis, it's typically defined underneath the public crisis pocket, which including health, emergency, and disaster. So our focal point today will be underneath the public crisis, underneath the health crisis arena here. But regardless, we need to understand the media environment, to understand the organizational decision-making process. Here, when we say organizational decision-making, including public health authorities and public information officers at national, global, and state, local levels with different resources and challenges. Okay, and also understanding public responses. How do they respond cognitively, affectively, and behaviorally? Okay. Okay, so we talk about the differentiation between public health risk and public health crises. Okay, so by definition, what exactly is the risk? So according to NIH News in Health back in 2016, we define a public health risk as a chance or likelihood that something will harm or otherwise affect our health. Okay, and risk doesn't mean that something bad going to happen, but it's a possibility. How do we inform the public about the likelihood in a precise and accurate manner, and including its characteristics and risk factors? So that's a challenge. That's a challenge, and that's also the commonality where populations and also traditional health communication comes in. Okay, but then comes to public health crisis. Okay, so here's a definition that one of my doc students who is now teaching at Oregon State University, Shurong Liu, we provided a working definition of public health crisis, which is to be published in the new handbook, Crisis Communication, second edition, included in Timothy Coombs and Shirley Holliday, their book. Okay, so in this book chapter, we talk about public health crisis and public health crisis communication. We define that public health crisis as a sudden and unexpected events that are caused by health problems, which can lead to inevitable physical, emotional, and financial harms to a rather wide range of stakeholders, publics, organizations. And the public health crisis communication is about a public health crisis issue or in response to a public health crisis threat to an organization and or its publics. So this is the definition that we proposed in this chapter, which will become kind of a guiding foundation conceptually as we're moving forward into this discussion later today. Okay, and then further, that another colleague of mine who is in UK, Dr. Vijay Kumar, we provided a encyclopedia definition about health communication and health crisis communication in another upcoming volume. We talk about that when we think about public health crisis, there are actually two types. So one is that we can all relate to something like COVID, something like H1N1, is that those are triggered by a virus. Those are happening very quick, it's emergent, it's acute. Those are kind of driven by communicable diseases like COVID, right? But however, the second type of public health crisis is actually called non-communicable diseases. In other words, the NCDs, caused by more like genetic, physiological, environmental, or behavioral factors. Think about heart disease, think about opioid overdose, those type of crises, right? So that kind of slow burn, that the effect, the harm takes over a long period of time, but it's less visible to a degree because it's not as emergent as COVID, as H1N1, but however, the impact, the emergence and then the importance is as important as more emergent type of crisis as well, right? So, but here what COVID presents an interesting case is that it is both emergent, but also because it has been lasted over 2 years of time frame, becomes both an emergent and prolonged public health crisis. So inevitably, throughout our discussion, I imagine we will have continued discussion using COVID as a focal point. Okay, so as I provided with Michael about the abstract of the lecture today, so the focal discussion point and really question to explore together, including how can we inform at-risk publics, both external and internal. Internal meaning the front nurses and doctors, employees as forefront of managing the crisis, raising accurate and timely information, and motivate our internal and external publics, their proactive actions. And the second question is, how do we sustain the ever eroded public trust in media and also public trust in traditionally held high trust entities such as government, such as public health authorities? How can we continue building, invoking the part of PR to strengthen our reputation in an increasingly conflicting and polarized media environment, particularly threatened by health misinformation and disinformation? And thirdly, how can we improve our communication management effectiveness and strengthen our resilience to build our community resilience and help individuals, communities, and our society across the globe to be better prepared for future public health threats? So I think the pathways to answer those questions may be many, and I think our doc students, our faculty colleagues, at this session right now, your research agenda is going to contribute to answering different aspects of the questions. So from my own research programs and publications, I would like to tackle and share with you how myself and my research team has been responding to this challenge via two focal points. One is how do we manage public health crisis information? And the second is how can we contribute by managing public health crisis and risk emotions? as felt, expressed, and challenged by our publics. Okay, so first, let's look into the informational challenges and opportunities. Okay, how do we manage public health information in a complex and conflicting media environment? Okay, so so in this part of discussion, also about emotion, I want to make a little background information is that I know many of our audience here are doc students. You're probably in the process of trying to work on identifying, navigating your own research stream or program from dissertation to the next 5 years or 6, 8 or 10 years as you become transitioning from an assistant professor to a more senior professor position. So for my own journey, my training, as Luke mentioned earlier, when I was a doc student, University of Missouri, I was trained more as a traditional public relations or traditional strategic communication scholar. My main program was about kind of corporate communication, organizational crisis, and risk communication perspective. It was not until when I was get tenured, I start to kind of translate my public relations and crisis communication framework into understanding public health research questions. Okay, so here, when I start talking about myself and my research team, our responses to public health crisis, I'll be showing you how some of those earlier framework designed not exclusively to address public health crisis, more from a public general PR perspective. How can we turn that into opportunities for PR scholars to claim a role in contributing to a health challenges? Okay, so here one example is that almost a decade ago, Brooke Liu, Lucinda Austin, and myself, we created the social mediated crisis communication SMCC model, right? So this model was developing to understand how organizations respond to crisis communication information flow on social media and offline. So for this one, later on, we applied and reshaped this model into understanding public health crisis, in particularly in the infectious disease outbreak context, because we found this similarity is that one, infectious disease outbreak is emergent, it happens suddenly, so this emergency mode gives this kind of traditional crisis type of flavor that we believe that we as crisis communication scholar, we can apply crisis communication model, especially in the digital space, into understanding how public health organization, how stakeholders, and how media respond and spread and disseminate, intercept, or further amplify information in that space. So this is the, we call that risk amplification through media spread model, which is really integration of SMCC model into a traditional risk amplification model into that space. So, well, we published this theory paper back in 2015. We got some traction, got some good citations. However, it was not until after March 2020, when COVID has hit all of us globally, that we got a communication from someone working in Middle East. Communication officer saying, hey, we read your article. However, you know, like all of these traditional academia papers, sometimes it's hard to grasp all those literature review, all those charts and tables. Can you provide us something that we can share with our public health information officers on the front line, so we can use your model in guiding our selection of channels, tailoring our messages to guide us into tackling the earlier stage of COVID communication. So in reaction to that, Vijay Kumar, myself, and Nowak, and along with a team of other scholars practitioners, we translated this original RUMS model into the chart to the right of the screen. We start to developing a menu. We share that with public health information officers. Say, hey, this is a translated version showing you at different stages of a infectious disease outbreak. How can you prepare? How can you talk about initial cases? How do we continuing monitoring, responding, inform the public, knowing that the channels are complex, the context communication is complex, and the parties involved are complex. Okay, So, and then one of the complications we're dealing with right now is the health misinformation. So by definition, health misinformation is any health-related claim of fact that is false based upon the current scientific consensus, right? So this can be contradictory, can be conflicting to the current scientific consensus, and which also can aggravate the communication channel by enhanced uncertainty and complexity. Okay, so this is another kind of misinformation components and its impact on determinants of health that were introduced and published actually in a publication in Brazil. So the original chapter was published in Portuguese, and this is the English translation version that our team developed to share with the public health information officers in Brazil. Okay, so here we zoomed in and focused on public health crisis misinformation. So we talk about that the agents who contribute to public health misinformation can be human agents, can also be bots, especially triggered and maneuvered by AI and disinformation. So the claim types, when we say misinformation claim types, can including attack on public actors such as doctors and experts and public health information officers, and especially using conspiracy theories to challenge the scientific findings. Can also be downplaying or creating panic about disease characteristics. So we argue that to address public health misinformation, we need to be mindful about the structural determinants and also the health disparities, and also the what makes different racial ethnic groups really vulnerable in terms of the accessibility, understanding, and health literacy and digital literacy as well. So we also identified intermediate determinants, including the damage that health misinformation can have on social cohesion and on our psychological well-being, and on the burden on health system as a whole. We also talk about, as public health communication officers and scholars, when we keep track of, when we're measuring public health outcomes as impacted by public health misinformation, including how does public health misinformation challenge or blur or creating damage on accurate health beliefs? How does that tarnish the lens for us to see health risk as is? And also, how does that change our risk behaviors? How does that damage the way we can prepare ourselves and our communities? Okay, so a few other evidence or studies that our team has been working on in addressing misinformation, public health misinformation challenges. So one of the studies that we did with my team in University of Amsterdam with Tony van der Meer is that we started to look into, are there any formula that we can developing in debunking or in challenging public health misinformation in public health crisis? Okay, so one of the formulas that we developed is that, okay, let's look at how about source and debunking strategy put together. So literature shows that the main sources of debunking, meaning challenging public health misinformation, that can come from traditional news media, can come from public health authorities / government agencies, can come from the peers on social media. So we're wondering, question one is, so which source is more important and more powerful comes to debunking public health crisis misinformation? And our second question driven by literature is that, so there are different types of debunking strategies. So which one might work better? So we identify two main types of debunking strategy. One is simple rebuttal. The other words is that less is more. Let's be direct. Let's be very firm. This is misinformation. Don't believe in misinformation. And the second option based on literature is factual elaboration. In other words, is to tell the story based on elaborated factual information. Okay, so which one works better in the public health crisis circumstances? So in this experiment, online experiment, utilizing a U.S. adult sample, we found that factual elaboration is more effective. In other words, which means for public health information officers, when you are confronted by public health misinformation, do not be afraid to gather factual information to tell your story in an elaborated fashion. And second takeaway is that government agencies and news media sources are still most effective sources in telling the truth, despite the increasing power of or more reliable trust on peer sources. So I think this is really good news for government agencies and news media, especially when we're thinking about the continued erosion of trust, according to recent data such as the Alderman Trust Barometer. There's still hope for government agencies and news media to play a critical role in public health misinformation debunking. And we also found that emotions like fear and anxiety, if those emotions being evoked in a proper dosage and proper amount, they can help, they can aid the effectiveness of factual elaboration debunking strategy. We also found that positive emotion, such as hope, can also help increase perceived crisis severity when the government agency and news media is the key driver of debunking the misinformation in the public health crisis surroundings. Okay, and then the third layer we found here is that so information vetting is a new addition of the earlier SMCC model. So for those of you who are familiar with SMCC model, the key information outcome we were looking at, including information seeking and sharing. But then we're like, wait a second, right? Especially confounded by misinformation, disinformation. So do people actually really just read information, then they seek more, and then they share with others? Or do they actually take a moment to sit back and verify, is this information I receive a public health crisis? Is this true? Is this semi-truthful? Or before I share with my family and my friends, do I want to take a time to verify the nature of the truthfulness? So it's based upon that consideration in another populations review article that we propose a information vetting model in which we argue that, yes, information vetting will be a very critical step in managing crisis information processing and consumption, in particularly important in public health crisis context. So we talk about there are two-step verification process. One is that based on the source, based on the content, we start to activating primary vetting. Is this coming from the source you trust? Does this information appear to be in good quality? If so, okay, I'm going to share it to my friends and colleagues and family members. But in some cases, well, for a more vigilant individual or social media user, you might go ahead to activate, we call that secondary vetting, which means, you know what, even though this information I received is against what my original belief and attitude about this issue, but because there are certain content, certain source cues triggered me to questioning my initial judgment, my initial thoughts, or my initial attitudes about this issue, about the topic. I'm willing to go back and have second thoughts about my initial thoughts. And that will kind of dive into a deeper vetting process. So before I share, I'm going to question not just information, but also question my own thoughts about my own judgment. By doing this double verification system, we argue that can help slowing down the impulse sometimes we're all facing to share too quickly by making honest mistake of sharing misinformation just because we think this might be true. Okay, so any questions, thoughts so far about the informational challenges and a few examples or strategies or takeaways that we share?
What is interesting when we have a health-related crisis, like normal trend is that audience are going more in social than and in like more elder people watch television, read newspapers, and blah blah blah. Don't you think that in crisis time people somehow change their normal information consumption? So they more rely on traditional mass media rather than to social media, even they because I didn't do research about it, but I'm thinking about it. Well, but when I'm communicating with my students who practically do not listen or do not watch TV at all, but in crisis times they start to watch TV, which is a little bit
Mhm.
interesting. What do you think
Yeah.
about it?
Yeah, absolutely. Yeah, that's a great question. And also when we think about the concept of media, right? So one of the focal question is that we talk about media, are we talking about the source or the channel? Right. So if we're talking about media as the traditional news media, even news media, they are always nowadays they have their traditional channel, which means the print newspaper or television or radio. But even the traditional news media has very actively using social media channels, right? So CNN has its own Twitter account, has their own Facebook account, have its own maybe Instagram or other accounts, right? So I think by doing that, the traditional news media as a trusted source still can have the social media presence, getting connected with younger generation who are likely to go to use Twitter. So the question becomes, so which source do they go to? For young people, when they use Twitter or when they use Facebook or when they use Instagram, or nowadays we talk about Be Real or other platform, right? So do they go to news sources, or do they go to influencers or other sources other than traditional media?
But
Right.
but don't you think it's the issue of trust? For example, when it comes about fashion, so maybe it's not reliable data, but it's fashion or it's, I don't know, cinema, yes. But when it comes about war, and it might affect your your
Mhm,
real life, so that like enemy troops of enemies
mhm,
might come to your city right now or after 3 days. We have in Ukraine, when the war started, we have a lot of YouTube channels where people just like
mhm,
broadcasted fantasies. They just write, and we started to watch this. I mean, in person, in our family, and we wrote to them,
mhm,
why are you lying? It's definitely not true. We know it for sure. This is not
mhm,
true. We didn't take this territory. And they say we are lying because we want to have more audience. People needs more positive news, and we provide it for them. So it's like a game for them. But while the television, at least they are responsible for what they're saying. We can sue them at least. Yes.
mhm. Yeah, yeah, and also that's a good point. And also with that, there are research shows that so when people's media consumption pattern, if you compare crisis versus non-crisis time, it's definitely different, right? So the crisis mode, so the sense of emergency, the sense of uncertainty can change the pattern or the clusters that media clusters we use to have access to information. Definitely.
I just want to make two observations. There's Ame Yang and I did a piece on this a number of years ago, looking at sort of who leads and sort of the media coverage. And the fact is that bloggers and tweeters, outside of the mainstream media, aren't in Kyiv, and they're not in other countries in Ukraine gathering data. And the news starts with mainstream media almost always, because they have reporters and they have resources. And then it filters into social media and people pick it up and start doing things with those messages. And so there really is, in terms of where it comes from, the agenda setting suggests the mainstream media are the leaders in this. And I think that's still absolutely true. And
Mhm,
then the other thing I would just want to observe is just that uh, we've got social media sort of changing the speed at which we do things and how we think about these things. And when Maureen and I, after ICA, we were in Geneva at the World Health Organization, and they had the worst practices in the world. They shook hands, nobody wore masks. Everybody was like, oh, we've all had COVID, so we're not worried about it. Like everything that they teach, they just ignored and pretended like they didn't even know. Maybe they didn't know it, I don't know. But it was really disappointing. And then it strikes me we've got things that have lasted for thousands of years, like religious belief. which is based on nothing but bullshit, and people believe it, and continue to believe it, but they won't listen to science. So there's a whole bunch, I think, of rhetorical issues here in terms of how the issues are talked about and how we bring them to people that we still need to understand.
Yeah, and also there's another topic, so I'll delve into in the next probably couple minutes, is that so the sense of fatigue, right? So at this point of time, after 2 years in the emergent and prolonged public health crisis, a lot of people are tired, right? So maybe at the very beginning you listen to public health authorities, you want to protect yourself. After 2 years, you think about talking about mask, talking about vaccine, you talk about just the name. Let's say COVID. Probably many of us is like, oh gosh, another COVID topic, right? So this kind of sense of fatigue, not particularly fatigue about one message, but just a general sense about this kind of crisis itself. We can call that crisis fatigue. That makes people become kind of maybe less sensitive to instructional information, becomes this kind of giving up, like don't care anymore. This kind of collective indifference about public health information communication. So it's very concerning. So how can we rejuvenate the conversation? How can we utilizing different strategies to make the dialogue become refreshed and rejuvenated, to really de-fatigue a already very tired public? It's health crisis, is the war and conflict, right? There's so many bad things all happening globally to everybody, to the citizens in different parts of the world. So how can we, and also all these crisis topics are competing in the news media agenda, right? At some point, COVID is the most important topic, and the next month, another thing's emerging. So this kind of sense of fatigue, sense of what am I going to do, who should I listen to, this kind of grand confusion that our publics are facing is something that we don't have quite a good solution yet, but we need to continue doing research and look into the potentially solutions from there.
Yeah, we have this communication campaigns, which I told you, and we have the communication campaigns for hard to risk population, rural people, people from minorities, elderly people, like LGBT and so on. So, and we have the message that it is shame to get COVID-19 while the country is in war. So with your, how to say, because you are so silly to get COVID, you are attracting some healthcare professional resources for yourself, instead to give care to people who were hurted by war, something like this.
Yeah.
And I think it worked. Like a shaming the public.
Yes, I'm glad you mentioned that, because in the next part of discussion about emotions, shame will be one of the topics that we'll be diving into briefly. We have more discussion about how can we understand different emotions, and sometimes we can use emotional appeal as a tool, but sometimes that can also backfire depending upon the situation. So on that note, let's segue into the second component about managing public health crisis and potential solutions, is to understanding the public health crisis emotion and coping, and continue exploring more effective public health crisis strategy and the proper dosage. Okay, so, and again, we're starting with a earlier public relations and crisis emotions theories that was published in Journal of Public Relations Research. Wow, it's like a decade ago. So in that earlier study, and we identified in any given crisis, you can see there are different types of crisis mapping out in this map here, that there are a predominant negative crisis emotions, including anger, anxiety, sadness, and fear, right? So this is not an exclusive list of emotions, but based on literature, based on research, those are the ones that we proceeded as in a given crisis that we as individuals are most likely to felt. Okay, and so later on we identified more types of crisis, more types of crisis emotions, including positive and negative, including shame, including hope, including optimism. And so in the context of infectious disease, threat, risk, and crisis, and in another before COVID research, we found that speaking of coping, mechanism and emotions, what exactly is coping or emotion and appraisal is that in any given stressful situation, at any given crisis that leads to stress, right? So as individuals, as stakeholders, as publics, we inevitably have to activate our mechanism to cope. So how do we cope with a crisis or a stressful situation, such as a public health crisis? We start to appraise, is this crisis, this threat predictable? Is it controllable? And who is responsible? And that appraisal mechanism can lead to different types of emotional reactions. So emotions can be positive or can be negative. And that, based on our finding, can lead to different kinds of coping, can help us predict where do they seek information from healthcare provider, from government agents, social media, from different sources and different channels. And that eventually found we're able to predict how to threatened individuals, do they choose to cope with the situation in what manner? Well, when it comes to coping, the coping can be either proactive or reactive or even passive, right? So the proactive coping, including we seek information, we follow instruction, we take protective measures, and then the negative or passive coping can including you deny the threat ever existed, or you avoid taking actions. As we see a lot, these mixed reactions, positive, negative, proactive and passive patterns in the past 2 years during the COVID situation. So further on, that so carry on this information of infectious disease appraisal model, we applied this model first tested in the US adult sample. We find a similar pattern in the US college student sample in different types of infectious disease outbreak situation. We applied the emotional flow theory in this particular study, where we found that hope as a positive crisis emotion is a very powerful predictor or mediator in help us explaining when confronted by different types of infectious disease crisis, how at least in this case, young adults, how their appraisal, if we can evoke hope in their senses after this being exposed to different situations, different messages, a strong sense of hope can activate or can motivate young adults to take a more protective action intention. So here's a strong argument that hope can be a good communication strategy or a target emotion for us to activate in our communication. And then a more recent study that we did in a cross-national survey project that our research team, we got a funding from Finland, and we collected data, actually 2 waves of data back in 2020 and most recently this year in the summer 2022. We look at how our participants in 6 different countries, including Australia, including US, Sweden, Italy, South Korea, Finland, and Italy, how citizens of different countries across continents respond to COVID-19 communication information coming from public authorities. What we found is, so in this particular study we recently presented in your prayer conference in Vienna, Austria, we talk about over time how a prolonged and emerging crisis such as COVID have impact on communication long-term effects. What we found is that the infectious disease appraisal model still apply over time. So the risk perception and COVID, the risk of COVID and the risk of COVID-19 vaccine, that the perception can trigger different kinds of emotions. In particular, in the study, we look at hope versus fear, which is one is very positive, one is very negative emotion. We also look into another dimension, is the attribution, shame or anger. As anger is an external attribution-based emotion. You're angry about someone else outside your organization, outside your individual entity. versus shame. Shame is something you attribute to your organization or to yourself, right? So we're curious about how do hope and fear as a differ by valence, and also shame and anger. It is negative, however, they differ by attribution. Do they make a difference or help us predict or explain people's behavioral coping level in terms of being compliance of a recommendation from WHO, from CDC, and also the intention of getting vaccinated as recommended by public health authorities. So in this study, what we found is that, yes, risk perception, the cognitive coping does predict emotional reactions. Emotional reactions do help us predict behavioral reactions patterns as well. Particularly, we found that hope and fear, well, the higher risk perception is actually leading to, over time, leading to less hope and even fear, which means that people are tired. At this point of 2022, the high risk perception leading to maybe less hope. What can we get out of the COVID-19 situation? And also less fear. We feel like we hear a lot about the danger. We don't feel as scared as we were back in 2020, right? And then shame is also another emotion, and anger as well. But what interesting is that fatigue as a moderator, we factor in our model, we found that stronger hope and fear can actually leading to more compliance in following public health authorities' recommendation, despite the fact that people are tired. On the other hand, when people are tired, shaming strategy is not working, which means when people are tired, if you're trying to make them feel shame, you're not getting vaccination, you're not following instruction, they only backfire. The more you're trying to shame publics who are not in compliance, the more likely that they are not going to be in compliance with the public authorities recommendation. Right. So the takeaway here is that let's work on evoking hope and fear. However, shame itself as an emotion already felt by publics, if you reinforce that might backfire if your goal is to motivate them to take further behavioral compliance recommendations as well. Okay. Yes, Michael.
Can I ask a question? So some of the persuasion research from decades ago suggested that sort of the big threat is you have two responses to the big threat. Either you ignore it and you sort of say this is stupid, or you of course embrace it and you believe that something will happen. And so there's this risk with the big threat about whatever you're going to die, you're going to get COVID, because at some point you feel like there's nothing you can do, so you're going to be defiant. But the other side of it is the research suggested that better strategy is a bunch of little threats, not the big threat, but a bunch of little threats like, long COVID, getting your friends sick, losing out on, activities that you could do, et cetera, et cetera. So instead of using the big thing, I'm wondering if any of that has been sort of integrated into this, because some of this just seems like you're looking at sort of one appeal going on here.
Right. So I think, Michael, that's a great question. So I think that it's, well, two responses quickly. One is that, so whenever we communicate about the threat, right? So there are always intended effect and also unintended effect, right? So the intended effect is that by articulating about the danger and risk, and with a solution, it's very dangerous. There are things you can do, and it's very durable. People are likely to take action to protect themselves, to avert the threat, to lower the threat into a safer, manageable situation. On the other hand, the unintended effects is that one of them is psychological reactance. So it's like, you know what, I know there's a threat, the things I cannot do is kind of the sense of hopeless, or the sense of you are telling me what to do. So you are really kind of in danger. You're challenging my freedom of choice, right? So that sense of you're trying to control me by telling me what to do, by telling me this is threatening my life. I don't need someone to tell me what to do. And that can trigger reactance, meaning I'm going to avoid you. In some cases, become very strong counter argument, or even doing exactly the opposite, right? So I think from health populations and strategic communication perspective, so there was an article I think published a few years ago in the International Journal of Strategic Communication about the concept of dosage. He said, the essence is that how much is too much, how much is not enough, right? So in our theory literature, we talk a lot about different strategies, but less so the dosage. The same strategy, just that we just keep pounding the same strategy again and again. Repetition creates reinforced memories and reinforce the behavior, right? On the other hand, should we really kind of strategically thinking about the interval of sending those messages, and so to avoid fatigue, to lower the risk of creating counter argument as a type of psychological reactance, or as Michael you said earlier, so maybe it's better to have different kind of different sub strategies. They come together serving as a grand strategy, but they each have its own strategically maneuvered dosages. So they sparsed out, but strategic come together. So they tell the same story in different angle. So it's now appear to be repeating the same messages again, creating fatigue and reactance. But it's really serving over time the purpose of persuading people without evoking unintended effects. So I think definitely, I think there's definitely a pressing needs, and current literature suggested that direction. But I haven't seen any particular research with empirical evidence testing the model have proved that this and that approach will be more superior than the traditionally the traditional approach of public health crisis communication strategies.
I have a quick questions.
Yes,
out of these countries, is there any difference effect depending upon country? Some of them are hope it's more effective and to persuade or recommend compliance in the behaviors. Is there any specific difference between the countries?
Comes to the whole the emotions. I think this so this model presented here is across the six countries we surveyed. This is the pattern we observed across the board. So I don't have the country specific result with me at this moment, but I can double check, Chris, and get back to you. But this is the pattern that summarizing the 6 country differences in our data set. So this is kind of applied to all the countries we surveyed so far.
Yeah, it seems like Hofstede is, the idea of culture, cultural variability is going to suggest that there's going to be differences by culture. And, although archetypes are, transcend cultures, right? So we've got archetypes that are perceived more or less the same across cultures, but we also have, cultures that are collectivistic and so would respond differently than a cultures that's more individualistic. So that would also be an interesting angle to look at.
Yeah, definitely. Yeah, so we do have, I think there are some country variants as we observe. If you look at individual model just by country, right? But this is one that we see that across the 6 countries, this seems to be a pattern. But in other studies, let's see, maybe this is the next one we'll be talking about. Yeah. So in this another result what we presented in the most recent IKEA conferences in Denmark. So it is from the same data set, but different variables here. But we, in this case, we are moving forward into looking at the emotion, but more like valence, positive, negative. Here, focus on negative emotions. We're looking into information source and message credibility, and how that might trigger or predict citizens in the 6 countries, their information coping by verifying information, and how they look for more information from different sources, expert versus non-expert, and how do their message fatigue from the beginning predict in general their pandemic fatigue. What we found here is that health message fatigue, which means individual messages about COVID-19 behavior, that directly predicts general COVID-19 crisis fatigue. Okay, and then there are multiple moderated mediators in this quite complex model as well. So what we found across the 6 countries that the sense of health message fatigue predicts negative emotions, and that and particularly coming from expert source is going to lead to more individuals seeking to vet information from non-expert sources, and the more informational vetting, the more information seeking behaviors, unfortunately adding to more pandemic fatigue. So also feel like, okay, so more expert sources you trust, the more negative emotions over time in 2020, you feel, you start to activating your own information seeking activities, your information verification activities or efforts, and then all of the, and then you start to feel tired about the whole health crisis situation. So that's kind of the essential story that in this paper, in this study that we presented at the conference. But in this case, I do remember that among the 6 countries, for Italy and for Finland, those are the exception that the trust in source, in expert source, was not a significant moderator. So which means in Finland and Italy, in our sample, that we didn't find that trusting expert sources make a difference in how their negative feelings felt is going to predict their informational activities or not. So that's one thing I remember seeing that from our data set. Okay. Okay, so a few key takeaways from some of these recent findings that, so there are crisis emotions, those are important. And crisis emotions, and particularly there are certain types of public health crisis emotions are particularly powerful in help us understanding and predicting citizens' reactions, particularly I think hope and shame, anger. Those are very powerful emotions for us to explore further together. And we need to understand the unique challenge that a prolonged and emergent public health crisis pose practitioners and citizens alike. And then we need to really look in deeper into coping strategies and understanding the patterns in the increasingly complex and competing media environment, especially given the challenges of misinformation and disinformation. And how do we deal with message fatigue and the general kind of crisis fatigue? How do we do that? How do we manage understanding intended and unintended effects? So as mentioned earlier, the strategy and dosage has to go hand in hand. So in crisis communication, we talk a lot about the crisis communication content and form, right? So here in public health crisis management, how do we really integrate both strategy and dosage is something we need to explore further. And also we need to continually sustain the public health authorities, their trust. How can we humanize WHO? How do we humanize CDC as coping facilitators in times of huge uncertainty and sustained stress and fatigue in that matter? Okay, and another comment I want to make is that in talking with public health practitioners and scholars alike, we found that there's a need for the scholars and practitioners to collaborate. But on the other hand, as we know, collaboration does not happen easily, right? So we need to continue doing translational work by conducting more collaborative research work. And another thing for us to keep in mind is that I know there are continuing challenging in public relations and crisis communication research is that there are so many collaborations and crisis communication research out there, but to practitioners in organizations, the agencies, do they use our research findings or not? As one of the studies published in JPR years ago mentioned is that practitioners very often do not apply crisis theory in practice. There are different reasons. There are article accessibility issues, then there are time resource issues, then there are translational and connection issues. So here, I think all of us here in this panel, in this session, we all share a burning desire to continuing bridging the gap between theory and practice. How can we really be translational and bridging the gap between public health communication, manage and research all together, right? So one of my favorite quote is that, so there's absolutely nothing more practical as a good theory, right? So some of those theories that we talk about today is something starting as a traditional population theory and later applied to understanding public health crisis and risk challenges. Some of them appear to be more translational than others. Then there are a lot of kind of gaps that are yet to be closed as we work on understanding the challenges altogether. So I would kind of close the slides guided discussion for now, and I will close the share screen, and hopefully we can start some dialogue and conversation as we are all diving into this very challenging arena altogether.
Okay, so many exciting topics. I was thinking while you were talking, we almost have enough of these crisis talks now. Another year or so, you could run a whole class where you get to watch a different expert come on and talk about their crisis, area, and then we spend the class going through those concepts and stuff. You got reading lists, but there's a whole bunch of, I think, interesting issues here. I'll let other people start us off with questions that they want to ask.
Sorry, may I again? I was trained as a practical public relations professional, and I started in the financial sector. And we were always taught that, for example, you should use this strategy of containment, like how French people say "pas de nouvelles, bonne nouvelle." So we try to press this agenda out of our company to not less talk, like more or less information. This is very good information. When it comes about public health sector, it's practically another, because we want people to do something. We want people to get vaccine, to vaccinate it. We still, for example, we just calculated that in Ukraine we have only 26% of vaccinated people by third vaccine. Because people, as you say, they are tired. They wanted to have a quick solution. Go vaccinate, no COVID at all. But it looks that it's still here. Do you see the shift in approach, in paradigm, with when we're talking about crisis communication, practice and strategies in this regard?
Mm-hmm. Yeah, so I think for one is that what makes public health crisis communication particularly challenging is that for the organization, let's say public health authorities, right? You are facing really double crisis potentially. One is that this is your job to inform the public about the public health risk and crisis information. Your job is to manage at least the informational element of public health crisis, right? So when you are not perceived by the public doing your job or doing the sufficient or as expected, then you are facing a reputational crisis, or at least maybe not even even a crisis, but at least para-crisis, right? Like example, the CDC, because CDC and WHO and many health organizations being blamed upon not being able to meeting the public's expectation, including expecting something more clear, constantly less uncertainty. However, the nature of complex health issue is uncertain. The facts, the scientific findings, the nature of a disease, the nature or effects or side effects of vaccines is still ongoing, right? So it's really challenging for a public health information officer or information authorities to balancing informing the risk and crisis at the same time, be really adaptable to really persuade or inform or the public. But part of the nature of public health crisis information is its uncertainty. At this point, here's the accurate information. So yes, we acknowledge uncertainty, but at the same time, to the best interest of all of us, you still should get vaccinated, despite there are things we do not know, right? So how do we balance acknowledging things unknown, but meanwhile, communicate, still motivate people to do the right thing? I think that's one of the challenges. That's where sometimes the misinformation or even disinformation becomes very handy, because the nature or the hallmark misinformation is that they provide you a shortcut. They showcase for sure this is going to happen, this is not going to happen, right? So it's really become very sneaky, because that meets the need for a mental shortcut. Unfortunately, the nature of scientific findings, the nature of scientific evolution is the opposite of having a shortcut. So public health information officers, how can we convey effectively in understandable, translatable language to concerned, very stressed, very emotionally laden, very tired public about that? Hey, I know you are tired. I know there's lots of uncertainty. However, this is the certainty that we know, right? This is why to your best interest, you should do this. So it's almost a combination of inoculation to a degree, right? So we know that you are confused. We know that there are things you're thinking about. We know there are other shortcuts available. However, this is the reason why you should listen to us. I think this is where I think the whole approach, which is untraditional to traditional health communication, is this co-creational approach that Maroon Taylor and Carl Bolton back in 2004 article has talking about, right? Really, it's a co-creational approach. I personally think that the co-creational approach becomes more and more feasible and durable given social media, given this kind of co-creational focused platform, right? So how can we really co-create health information messages that's really engaging, really defatiguing, really unconventional, but effective? What can we do about it? Maybe humor is something we can do. Maybe there's some alternative emotional appeals that can evoke hope, that can turn negative emotion into positive outcome, right? So I think there is something about co-creational approach in contrast to traditional preventional one way telling you what to do that sometimes can be interpreted as condescending from layman perspective. I think there is something about that, about building trust, about truly being equal. We are talking with you, we're co-creating messages that matters to you. I think that might hold the key for future more effective health crisis and risk communication messaging programs and campaigns.
Speaking of the co-creational approach, I had a question exactly relevant to this concept. So is it true to say that public health organizations or generally public health communication is less co-creational? Because, for example, in co-creational approaches, we engage with community groups, we ask for their ideas, we listen to them, and then we craft our messages based on the insight we get from the community. However, this might not be much the case in public health communication, because especially in the context of acute diseases, there is urgency, and also the messages needs to be based on hard science. So is this true to say that, and of course, for example, in your research, you also had focus on public's view, but it was mostly about public's emotion or how they share information or how they evaluate information rather than how they inform messages. So I'm wondering if it is a true claim to say that public health organizations are less co-creational compared to other organizations.
Right, so that's a great question, Shima. Because by definition, I think by listening to the community, to the stakeholder, and gather information and then incorporate that into your messaging design, it is, you can say that's two-way communication, but it's not the ideal, by definition, co-creation, right? Because the audience, the stakeholders, they are not part of the really creation of the message of the implementation itself quite yet, right? So I would argue that the gather information, incorporate the findings into the message design. It is a great approach, reflecting the stakeholders' opinions into message design, but it's not really an ideal co-creational practice, not quite there yet. So I'm thinking about, there's some literature about, another example, let me put it this way, it's about tailored health messaging. I know this is a concept we talked about for a long time, right? What is tailored health messaging according to individual health risk and needs? But how do we actually do that effectively is still yet to be explored. So there are, if you look at advertising literature, there are concepts talking about personalization and customization, right? I think these are some approaches similar to this kind of co-creational model. So the challenge would be for a public health organization to be truly co-creational, they need ambassadors, they need stakeholders that to be actually at the decision-making table to truly co-create something that's theirs. It's not just we listen, here's the research results showing that you want to hear this. So I wonder, because example would be, there could be potentially a co-creational campaign, say on social media, right? It's co-created by, say, a health organization or a public health agency or a health nonprofit. They truly activate, say, the youth community about mental health issue, about cyberbullying type of mental health concerns. They really kind of launch a campaign is driven not just by the health organization or the nonprofit behind, but it's driven by the audience who have the concern. So I think if we can do something like that, that becomes truly reflecting the core of co-creational as defined by Taylor and Bolton back in their 2004 article. So, but I think there's definitely obstacles and challenges. It comes to feasibility, comes to and resource as well. Especially thinking about one of the articles I presented earlier, when we talk with the public health information officers at the state and local level, one of the challenges that for a health information officer at a state or the city level, right, very often it's one person does everything. You write a press release and you design a flyer, you meet with concerned community in the city hall. But it's given the resource and your role and how much you can do, make co-creational not feasible at all, right? So what kind of resource, what kind of feasibility, what kind of support that institutionally can make co-creational really durable? I think that becomes a bigger strategic and managerial and system question that needs to be addressed to make the co-creational model approach truly sustainable and authentic.
I'd like to follow up on Chima's question too for a second. The classic model, like the situational theory, right, had our 4 models of public relations, and the first, press agency, public information, and those were asymmetrical models. And in many ways, health communication still is this asymmetrical process where you've got messages going out to the public about what they should do. In the classic model, right, press agency, the truth wasn't important, but in public information, the truth was essential. But at the same time, if you've got this need to co-create, right, if we're shifting away from the one-way messaging that we're used to do into this co-creational model, and we start getting into this, how do we convince people? How do we get people to create the same reality? So it really is a completely different thing. I think, like something like this, a long-term pandemic is completely different than what we've dealt with before.
Yeah, and another layer of kind of challenge co-creation is that how do we co-create when we're confronted by competing and competitive information, right? So people, as we know, the polarization is a big challenge we're all facing, the uncivil discussion online, and also this intolerant attitudes toward people who have different points of view, right? So how can we truly adapt using co-creational stance as an approach to say, hey, despite we have different values and different things, but can we truly listen to each other and find out solutions based on shared value and interest. So in my perspective, I think this makes co-creational approach more important, pressing, and promising than ever.
I have a question about social media. Don't we are too enthusiastic about social media? For example, yes, when it started, like when this digital revolution started and everyone went to social media, we start to say how someone told give public back to public relations. Yes, so everyone has a microphone, everyone has a voice to be heard, and now you open your streaming in Facebook and you see on the advertisements. So 90% of your posts you can watch. It's actually the commercial information provided by someone who paid for this to Facebook, and I think that the tendency is the same in Instagram and in other social media. So don't we are too enthusiastic about it? What do you think about it?
So one quick reaction is that, so I think as social media users, we also have our social media reactants to a degree, right? So one of the most recent discussion I had with my students is this new social media platform. It's new to me, called Be Real. Maybe someone younger like Alvin, maybe you use that, or Chuqing already. Be Real. What is Be Real? I was told Be Real is the anti-Instagram platform. You don't have to pose, be perfect. You just be chill and just tell us where you are or what are you doing, right? So and then we talk about, so what if in the future populations and PR or the commercialized persuasion invading that space, would Be Real still be real according to their currently what makes Be Real so popular? On the other hand, you think even thinking about the streaming services, right, like Hulu's and others, and Netflix. So there is a trend. People are kind of tired of the streaming, at least some audience tired of streaming. So back to using cable, right? So there's almost like fashion, right? The 70s, 80s fashion come back this year or next year. I think the social media pattern, we have too much Instagram as the social media users. We go back to something maybe more traditional social media consumption. So I think there is this kind of little spiral going on in our social media consumption patterns and preference. Again, back to the dosage, right? How much is too much? To what degree social media users are going to seek alternative, even the opposite of the trends we're looking for. Maybe at some point, we're tired of so many different influencers, the social peers, back to the original information source, such as traditional news media and government agencies. Granted that the trust erosion can be repaired in time.
It's interesting to hear, all of the discussions about these longer term impacts and relationships, because in some ways it harkens back to the need for public health organizations to act like every other organization, right? And follow the same kinds of public relations theories that we apply in all of these other contexts, both in terms of, relationship building and trust, as well as Michael and others have pointed to in the chat, the need to consider sort of ongoing conflict-oriented approaches to public health. And you mentioned a little bit a few minutes ago about in the polarization and politicized aspects. And I'm wondering if you had, because I haven't seen any, and I might have missed it, any of your research that specifically looks at communicating health crises in polarization, but is that an issue you're looking at getting into, and how might you approach that?
Yes, that's a good question, Luke. So might not be solutions quite there yet, right? But a quick kind of episode to share with you was that, so in our crisis communication think tank, we meet every year with a group of crisis communication scholars and practitioners. So in the past April, our theme is called POP, Power of People. So our thought, we originally look at polarization, but we decided, instead of looking at the problem, polarization, let's look for solution. So we believe that the solution is actually lies with all of us, the power of people, right? Even the Constitution starts with we the people. So, so in our discussions throughout the event, we found that one of the challenging is, So the people start to kind of continue to disagree with each other with different interpretation of focal issues. When you do not listen, do not engage in civil debate or conversation with people disagreeing with you, when the echo chamber continues to expand, right? So I almost feel like what missing is this kind of, we call that information kind of mediator, right? So if you look at Shah and colleagues' 2017 articles, I think published in Human Communication Research, the authors, they talk about conversation is actually a key mediator of media influences, right? So, but what happened now, danger is that the mediator, media effects, conversation has been damaged because the conversation is not happening. There's a disorder. We no longer have healthy, open, civil, and tolerant conversation with people with different points of views. So I think for me, that's the focal point. If we're going to fix, if we're going to make, at least enhance or kind of trying to make a difference in addressing toxic polarization, we need to go to ask ourselves, how can we help as communicators, scholars, identifying how can we enhance conversation, addressing the in-civil conversation issue? How can we address the enhanced tolerance towards the attitudes towards the different points of view, right? So who are the mediators we can all go to? So actually one of our takeaway from our think tank outputs is we need to identify the mediators. So say, look, I disagree with you, and look, you disagree with Chris, right? But there's somebody in this group. Maybe it's Michael. We all like. So we don't like each other. We disagree with each other's points of view. But when Michael is here in this room, in convening all of us, we will at least sit in the room and listen, right? So is that the role for traditional media to take, for influencers to take, or co-creation approach, something co-create is kind of mediator. But for me, I think that's something that might have some potential theoretically and also practically for us to look into.
Thank you.
You're welcome. Thank you for the question.
So you can't hear me. Anybody want to jump in with a question who hasn't asked anything yet? Rodney, you got your hand up?
Thank you, Sir Michael. And Jane, thank you so much for your presentation. I was not here. I was a little bit late, but I just want to know how much does culture impact crisis communication?
Wow, it impacts a lot. I remember in 2018 ICA conference in Prague, in one of our sessions, we had a discussion about the gap or future directions of crisis communication research. I remember we talked at least among the key directions. I remember two very vividly. One is the concept of time. Right, so we tend to studying crisis in one section, but actually the crisis management, conflict resolution, it takes over time, right? At a given point of time, there are different emotions, there are different truths or different information, uncertainty, so that needs to be delved into along the crisis management process. And the second focal direction we talk about is actually the cultural effects, right? Because if you look at the current predominant crisis communication theories, it was very much Western centric, right? So does that really apply to different continents? Does it apply to Asia, Africa, Australia, New Zealand, and other part of the world? It's I think the big question mark still remains. You must think about even macro level, even emotions, right? So different cultures have different emotional reactions to a situation. So the saving face desired by a certain culture might not be desired or even considered very negatively in a different culture. So I think culture differences is one of the most important, very important nuanced cultural, organizational, and individual characteristics that needs to be factored in all crisis communication research. Absolutely. I think something really lacking. We need more researchers like probably like you yourself to continuing helping us advance our knowledge in that area.
Okay, we have Shuking coming back in. She's apparently was switching to her computer and she wanted to ask a question, she said. So I think in 1 second she'll be back in, or maybe here already. There you go.
I'm back, and I'm
Hi.
sorry I missed the first section because I calculated the time difference wrongly, but I was able to catch up with the second part, and I'm particularly interested in the model with message fatigue and the pandemic fatigue. And then we had the conversation about co-creational model. I'm just wondering whether you have found anything in your previous studies from a practitioner's or communicator's perspective regarding their message fatigue and their pandemic fatigue, and how do their fatigues impact their way of engaging in crisis communication and health communication during the crisis time?
Yeah, thank you, Chuxing, for the question. So, so your question is about how practitioners, our own fatigue level or emotional burnout might have an impact on how we do our job in communicating, defatiguing our publics, right? That's a good question. We haven't done research about how experience fatigue among health information officers yet, but I think that would be a great study for us to do. But there are, let's see, relatable studies could be, so in the earlier study that I did with Glenn Cameron back in 2007, so we did a online experiment with studying how emotional reactions that PR practitioners felt in dealing with organizational crisis might have an impact on their counsel, their recommendation, for their companies' organizations. So I would presume that based on what we found, that indeed practitioners, our own emotional feelings, our emotional reactions, discrete emotion, emotional arousal, and our emotional intelligence as personal trait that do affect how we make decisions on behalf of our organization or recommending organizations to do. So I would imagine that that can lead to plausible hypothesis saying that for fatigued practitioners in public health crisis situation, that is going to have effects on their performance and also even on their public health recommendation. But I do think the silver lining could be when practitioners like you and me, when we feel tired, we can, based on our empathy and compassion, we can relate better to our patients and publics, right? You know, I'm tired, you are tired. So let's co-create. Hey, here we go. Let's co-create something, you and I, inside and out. We can all relate to. So maybe that threat and challenge can turn that into an opportunity to be truly empathetic, to be truly compassionate. And also, I want to tie that back to Rodney, your question about culture. Like, we think about culture is more than just the culture by location, culture by geographic differences, by country, by history. Because culture can be also organizational culture, can be the industry culture, can be at a macro and micro level as well, even for a team. And Chris, you know, based on your management experience, right? So every communication team has its own culture, right? So how can we boost the sense of culture and defatigue even with among teams of health practitioners? Back to choosing your question, I think that also matters. I think the culture rejuvenation, the culture resilience, especially in the public health crisis, in a prolonged crisis setting, needs to be rejuvenated from within. And then that within rejuvenated culture, defatigued sense of refreshments can translate outside, make our own communication messages to external stakeholders really genuine and authentic.
Thank you.
Thank you.
Anyone else?
I have one quick question.
Mhm.
Yeah, you know, I'm keep thinking about the connection between co-creational approach in the IDT, right? Infectious disease is very imminent and have a direct impact to human casualties, right? Then in that case, I'm keep thinking about what might be the right timing or some strategy to orchestrate. Some might be more strong one way, persuade a message, send it out, and then the other case probably later on we can create approaches, some co-creational message or something, right? So is there any Yeah, Michael once suggested that we need some kind of model to handle some prolonged weight problem or something. Is there any study that you are working on the component, like a message strategy or considering the public copying strategy or something?
I think some of our ongoing projects can tie into kind of emotion and coping, but we're not looking at specific kind of co-creational strategies quite yet, right? But I think that's the direction. Continue doing. How do we tailor health crisis risk communication messages towards infectious disease threats? So I think the equation, I think variables will be many, but at least two would be you have to factor in. One is the psychological mechanism, individual differences of the receiver, right? And the second one has to be the nature, the characteristics of the disease threat itself. So as an example, right? So as of now, we are dealing with multiple infectious disease threats as we speak. We have continued COVID with different variants. And then we have flu, and also at least in the US, the flu season is particularly bad, at least worse than last year, right? So if you walk through the Atlanta airport the other day, you see this banner from the Department of Public Health in Georgia saying that, hey, kind of double your health security by getting both your flu shot and COVID booster. Next time we go see a pharmacist or go see a doctor, right? So at this point, COVID, but flu, we all know about flu, right? So even the risk level might be higher or lower by year. But when we hear about flu, I feel like, oh, yeah, it's something we know. Maybe the perception of risk level is lower because it's not novel. We feel like it's more controllable, predictable than other type of emergent disease. And COVID, 2 years ago, it was novel, it's emergent, it's very dangerous, serious, and perceivably more serious than flu, right? But now at this point of time, do we perceive the danger risk of flu of COVID-19 at the same level as flu or not? And then earlier this fall, when the monkeypox, another infectious disease outbreak, is happening in the U.S., right? So people there are a surge of fear, at least at one point. But at this point, do people still have the sense of fear or sense of urgency still go to get a vaccination among vulnerable population? So I think that's kind of tied back into our kind of human psychology, our human nature, right? So when something's novel, that's something once upon it's novel becomes less novel, becomes we get used to it, right? We adapt, we get used to it, but doesn't mean the danger is off. So how can we really kind of align, constantly align the lens of a health practitioner with our personal individual lens? So what exactly is the accurate picture of the risk level and what to do? I think that lens has to be constantly traditionally carried by public health information officer, but can we find a way that us and stakeholders, individuals, we co-create that lens, co-adjusting with better alignment, with better caliber all together? I think that's probably something at a grander strategy level, but what to say, how to say that can be tailored. But again, I think that approach needs to be taken place from starting with our research community perspective.
Good. I'd also just mention a couple who came later. We did, Yan talked about some of these issues earlier in her presentation. So the video, I'll try to post the video later today. I usually have the YouTube video up by the end of of today, and then I have the one on the homepage up by the next day. But you might watch the rest of it, the front end, if you want to catch some of the stuff you missed for those of you who came in late. Okay, anyone else? Okay, I think maybe we should wrap it up then. It's, you did a nice job. It was very interesting. Great talk. Thank you for being able to come to this today.
Oh, thank you. It's my pleasure. Thank you, Michael. And thanks to everybody in this great conversation. And I learned a lot, get inspired by our discussion. So let's all working together in our different projects, and maybe perhaps there are ways for us to collaborate in the near future, continuing making good waves and advancing our knowledge and practice in different parts of the world.
Yeah, this is, I think, what we miss, like
Thank
with our students don't ever give us this, we don't get to talk about complex ideas. You got to like struggle to get them to just turn the camera on. But, it is fun to be able to sit with a bunch of smart people and we talk about stuff and we ask hard questions and, so I think it's a lot of fun. All right, well, thank you. I'm going to stop the recording in case anybody want to say anything now. Now's the time. Stop recording.